Welcome back to Diabetics with Files, where we don't just treat wounds, we decode them. So, a rocker bottom foot isn't just a collapse, right? It's not just a collapse of the arch. It's the end stage of a silent structural failure driven by neuropathy, repetitive microtrauma, and unchecked inflammation. It begins with a patient who doesn't feel the damage, progresses through fractures that go unnoticed and ends with a foot that literally reshapes under pressure, shifting its load to places it was never designed to be. So, in this episode, we're going to break down how that collapse happens, what it means biomechanically and clinically, and how to recognize it early enough to stop it before it becomes irreversible. I mean, once it gets to that point, most of the time you might need reconstruction, but it's not just a deformity, Charcot foot or the Shaka rocket bottom foot. It's an architectural failure under silence. So this rocket bottom foot isn't just the collapse, it's the end stage. So who was the first person to describe pretty much Charcot, right? Because a lot of times when people discover things, they named it after themselves. So the condition is first described by Jean Martin Charcot, but this wasn't in diabetes. It was actually in syphilis. So picture this: Paris in the 1800s. Patients are coming into the hospital with something strange. Their joints are destroyed, knees, ankles completely unstable. But here's the part that everyone was confused about. The patients were feeling no pain. They had no pain. And these patients actually had late stage syphilis, what we know now call tabes dorsalis. Okay. So TABES dorsalis. And this is a neurological complication of untreated infection. This is completely different from diabetes, Charcot. Okay. But I'm explaining the history of Charcot, okay? How they got to know it, because what happens is in late stage syphilis, they have neuropathy. Okay. So in late stage syphilis, the bacteria attacks the dorsal columns of the spinal cord, and those are the pathways that are responsible for positional sense, vibration, and deep pressure awareness. So, in other words, the brain loses awareness of where the body is in its space, right? And so when these patients walked, they couldn't feel joint position, they couldn't feel stress, they couldn't feel the damage. And that sounds just like diabetes, right? And they kept on walking. And so they kept on having repetitive trauma, joint instability, and progressive destruction. And Jean Martin Charcot saw this and realized this wasn't infection destroying the joint, it was loss of sensation. At least he was intelligent enough to figure that out. So fast forward today, we have diabetes, okay? They are not the same disease, okay? But in both conditions, you lose protective sensation, the feedback loop from the foot is compromised, and the awareness of injury is compromised. So you're removing the feedback loop because you have loss of protective sensation. So where do they differ? Because it's a pathway to destruction, right? It causes them to have the rocket bottom foot. Charcot, but it's not identical. So with syphilis, tapes dorsalis, it's the central nervous system damage. It's loss of proprioception, which is your positional sense. It causes severe joint instability and often affects larger joints like your hip, your knee, and your ankle. It's a coordination problem. But in diabetes, not syphilis, this diabetes, this is where we're more focused on, okay? Because that was just historical facts. Diabetes, the patients have peripheral neuropathy. They have loss of pain, temperature, and pressure. They have microvascular disease. They have inflammatory bone reabsorption. It's a sensation as well as a metabolic problem. So you have to remember in diabetes, the foot breaks down because it can't feel the damage, it can't heal properly, and the bone is biologically weaker. And diabetic Charcot as something different that Charcot never saw, the syphilis Charcot never saw. And it's that inflammatory cascade, the inflammatory cascade of cytokines, osteoclast activation, and the bone literally dissolving under stress. So whether it was syphilis back in the 1800s, and that is not the same as diabetes, that was just a historical fact of how they discovered it and discovered that it was a loss of sensation thing. It's was similar causes, okay? Which is loss of protective sensation, but with diabetes, Charcot, it's more in an inflammatory state cascade as well, okay? So just the key factor is like Charcot foot isn't just about diabetes. It's about more about the loss of protective sensation, that neuropathy, and that inflammatory cascade because it's a metabolic problem as well. So, what is the rocket bottom foot? So I can clinically visualize it for you. So the rocket bottom foot is you have a midfoot collapse, a convex plantar surface, a loss of the medial longitudinal arc, and often from Charcot neuroarthropathy. Okay, we call it Charcot neuroarthropathy. So mechanically, our foot goes from a tripod to an unstable platform. That's why, like, when you see if you step on dirt, right? Or even on the pressure mapping, your foot makes pretty much a tripod most of the time. And the apex shifts, you know, plantar and central. And this happens when the midfoot bones fracture, the ligaments fail, and the joints dislocate. And then the arch drops below the forefoot and the hindfoot. And that's what creates the rocker appearance. And the key anatomical zones are the tarsal metatarsal joints, aka the Lisp franc, the naviculo, the naviculo cuneiform joint, and occasionally the talonavicular joint. So the pathophysiology behind diabetes, Charcot, neuroarthropathy, this is I'm going to try to oversimplify it. So the three core drivers are one, neuropathy, our loss of a protective sensation feedback. So the patient cannot feel the microtrauma and continues to walk on the fractures. Two, the repetitive microtrauma, the tiny fractures accumulate, the ligaments stretch, the joint instability increases, and then the neurovascular dysregulation, the increase in blood flow, forgive me, aka which causes osteopenia because of the neurovascular dysregulation, and the bone becomes soft and collapsible. Now, the inflammatory cascade, which makes it stand out for diabetic neuroarthropathy, Charcot, right? The trauma causes the cytokines causes the osteoclast activation. This causes bone reabsorption more happens more than the bone formation. Bone reabsorption is overpowering the bone formation, and the structural failure accelerates. So the collapse sequence for Charcot is usually midfoot stress fracture, ligament failure, joint subluxation, arch collapse, plantar bony prominence, and rocker bottom deformity. Now, classification system for Charcot, diabetes Charcot. The Eichen-Holtz staging system, you need to know this definitely. So stage 0 is pre-Charcot, so that's when the foot is hot, red hot swollen, normal X-ray, MRI may most likely will show bone marrow edema. Stage 2 is the fragmentation stage. You will have fractures, dislocation, and severe inflammation. Stage 3, you will have the coalescence stage, which is healing begins and there's less inflammation. Stage 3 is the reconstruction. The deformity is fixed, often ends up in a rocker bottom position. Now, they also have the anatomical classification, which is super important for us podiatrists. So type 1 is forefoot. Type 2 is tarsal metatarsal, which is the most common one, which causes the rocker bottom foot. Type 3 is midfoot hindfoot. Type 4 is ankle. Type 5 is calcaneus. So the biomechanics, why the foot feels. So let's look at like an engineer. So normal foot, we have our load to from our heel to our midfoot to our forefoot, right? So from the bottom to the front. So our arch is our shock absorber as well as it absorbs as well energy return. But in a Charcot foot, the arch is collapsed. So the load shifts to the midfoot plantar surface, which creates a new pressure point and an unstable lever arm. Now, there's also going to create a tendon imbalance. The Achilles tightness, the forefoot overload will cause that forefoot overload because it causes the quietness, right? The posterior tibial dysfunction will be because of arch failure, will cause arch failure. And then our intrinsic muscles are weak. Remember the term intrinsic minus foot? I believe I did an episode on that. Now, our joint breakdown sequence is Lisfranc instability, navicular cuneiform collapse, and talonavicular destabilization. So early Charcot, we did an episode on Charcot cellulitis because early Charcot is missed often. Quite often is misdiagnosed. So you have to look for one foot is hotter than the other, swelling without trauma, redness, minimal pain. Patients often keep walking on the fractures. Okay. So how do you identify it? Temperature difference between the contralateral leg, right, is going to be greater than 2 degrees Celsius. Midfoot instability, a boggy swelling. And, misdiagnosis is such a tricky and very dangerous thing, especially when you don't have the right diagnostic tools there. So I would always play it safe and play it cool. Play it safe rather than play it cool. Be very aggressive when it comes to diagnosing diabetes, in my opinion, because if you miss something that is kind of mimicking it and it turns out to be like a thriving infection, that's horrible. So it's better to be safe than sorry. So imaging, X-ray, MRI, you can get an MRI or a CT if you're doing surgical planning. So what type of ulcers do we see when it comes to Charcot? The deformity creates high-risk ulcer sites. The plantar midfoot is the most common, the cuboid prominence, as well as the medial arch collapse zone. And why is that? Because the bone is now the lowest point, and the pressure is because of constant and unrelieved pressure. So why does your shoe size change? Because a lot of these patients who have Charcot, they still try to put on regular shoes and it's really hard. So they end up wearing slippers. Okay. So patients will say, my foot got bigger. They're not wrong. The foot did get bigger. So the arches collapse. So the foot lengthens. The forefoot abducts. It goes away from the midline. The midfoot widens. So your old shoes are not going to be able to accommodate this new structural deformity of your foot. So that's why you should get a custom shoe. Custom shoes are a non-negotiable. So normal shoes are flat, have a flat last, fixed pressure zone, Charcot foot, irregular geometry, plantar prominences. So you would need like a custom depth, a rocker sole, and then sometimes people put total contact inserts in it. And then our shoe goals are to redistribute the pressure, offload the midfoot, and stabilize the gait. So most likely you have to go to an orthotist, somebody who specializes in making shoes, right? Now, physical therapy. PT is not primary when it comes to the acute phase, but is needed in the later phase because you have to focus on gait training, balance training, as well as proximal strengthening, to help us avoid overloading an unstable foot. Now, our non-surgical option, gold standard for Charcot is mm, immobilization, like a total contact cast, right? Why? Because it evens the pressure distribution and immobilization. Alternatives are cam boot, a crow, or a wheelchair with offloading, right? But what if the patient can't use a TCC or a CAM boot? Because in real world medicine, let's say if the patient is elderly or frail, a removable CAM walker and strict compliance, that's not really that feasible. You got to think about felt padding. You got to also think maybe wheelchair or bed rest, but also we have to think about the risk because most patients will still continue to walk on it and the collapse can progress. So what are some of the surgical options when it comes to a rocker bottom foot? So they usually reserve surgical options or interventions for a rocker bottom foot for instability, recurrent ulcers, as well as severe deformities. And you have to remember the quality of the bone is kind of messed up now. So usually people do extectomy, which is removal of the bony prominence, or they will do an arthrodesis, which is fuse the unstable joints, or they will use internal fixation like screws or plates, or external fixation like an isobar isobar frame. And forgive me for mispronouncing that. But the end of the surgical goal is to create a plantar grade stable foot. It might not look the prettiest, but it is functional. So why does it keep breaking down? Because neuropathy still persists. The patient will continue to walk on it, the bone quality is poor, and the deformity creates new pressure points, and it creates a cycle of destruction. So, what are the latest research insights on this, modern understanding, because it's not mechanical, it's an inflammatory as well as a metabolic problem. So the key concepts are they call it rank L mediated bone reabsorption, cytokine driven osteolysis, as well as neurovascular imbalance. And the clinical truth is that charcoal does not destroy the foot, the delay is. So who do we refer? Because you don't manage this alone. You refer to podiatry, or you could refer to orthopedic and ankle, definitely wound care, and definitely endocrinology. Okay. And what are our preventive strategies? Daily foot checks, temperature monitoring, early offloading, and glycemic control. Because rocket bottom foot is not just a deformity, it's a timeline of missed opportunities when it gets that far. And you know what? The run rule is teach your patients. If one foot is warmer than the other, stop walking, contact us, get appointment, come in. Okay? So we can know exactly what to do. And this is just another differential. Okay? So this is diabetic foot files with Dr. G, and take care of your feet because they take care of you.